Yes, welcome to the Asthma Advisory Panel. We're excited to have the topic on expanding asthma-friendly best practices in schools. We have a nice array of speakers today to address the topic and share, and we hope that time depending, we'll hope to have time to also share and discuss a little bit. But we want to focus on this topic another, relatively soon. Next, in a couple of meetings to dive in even a little bit more deeply. At this point, I'll just go ahead and turn over. Well, one big announcement is we're very happy to be joined by our new asthma program manager, Dr. Kanagavali, and I'll move to oversee our new COPD program and then support Vali and the respiratory health program. And so at this point, I'll turn the mic over to Vali, and she can introduce herself a little bit and do her presentation. So thank you, everybody, and we're all very excited about this. I am. All right, take over, Vali.
Yeah, thank you. Thank you so much, Karen. Hello, hi everyone. My name is Kanagwali Madhivadanan. I prefer to go by Vali. I'm a new asthma program manager in the Department of Health Promotion and Disease Prevention. I just joined recently to the Vermont Health Department, and I have a background in Master of Science in Public Health from Johns Hopkins Bloomberg School of Public Health. I just recently graduated, and I also did my internship in WHO. So yeah, today I'm going to present about impact of uncontrolled asthma in school children. So let me give a minute. I'm just going to share my screen. See? Yeah. Okay. Can everybody see my screen?
Looks good.
Okay, great, perfect. So yeah, as I said, today I'm going to present about impact of uncontrolled asthma on school children. So we all know the asthma prevalence is very high in Vermont. Like 8% of the children have asthma, which is current asthma. If you see this chart, like overall in the lifetime, they have been told, children have been told that the 13% someone has an asthma in their lifetime. So if you see the chart on this right side, so the well-controlled asthma is 39%, but the concern here is like uncontrolled asthma, which is 61% in children. So why we need to speak about asthma? There are, of course, there are a lot of diseases and which has a very high prevalence in asthma, which are other than asthma. But why we need to speak about asthma? So I'm particularly concerned about the high rates for uncontrolled asthma in children, and it's a chronic condition. So I also believe that if it can be well managed and if it can be like well prevented, and we can reduce uncontrolled asthma and can reduce the impact it causes on the children. And last but not the least, the uncontrolled asthma or any asthmatic forms, it attached with the sigma, which leads to other complicated forms of like consequences like health disparities that can lead to a reduced um, opportunities to improve a health equity as well. So this is why we need to speak about asthma, and it's really important. It's the time to speak about asthma. So, what are the challenges that can lead to uncontrolled asthma, especially in children? There are a lot of factors that can lead to an uncontrolled asthma, but not limited to low health literacy and low socioeconomic status, and also disparities in access to healthcare. Going to a ER visit is very expensive. That ultimately puts a very financial burden on the family. This can be one of the challenging and poor medication adherence may be due to a lack of self-awareness or any lack of awareness about the how to manage. So that can lead to a poor medication adherence or sometimes using just only a rescue inhalers. And also sometimes it can be environmental triggers, secondhand smoke, pool and mold dust, and essential oils, which my colleague Michelle is going to speak about that in the session, and also environmental triggers like virus and cold, and also can be doing an exercise. That can be one of the challenges for this uncontrolled asthma. So, what impact it caused on the children? There are a lot of factors we have seen on the challenges on uncontrolled asthma, but these challenges can lead to very unintended consequences on the children, which ultimately leads to um, missed school days because of the severe asthmatic attacks. That it can lead to missed school days, and if there is like emergency ER visit to control severe asthmatic attacks. And due to this uncontrolled asthma, children may have experienced poor sleep and fatigue, which ultimately leads to a reduced focus in their studies, and also the reduced focus in their concentration and everything. If it's like not managed very well, it can lead to a risk for permanent decline in the lung function. So the it has been shown from our data, like more than 1 in 6, like that is 18 percentage children has missed school days at least in the last 12 months. And if you see the graph on the right side, overall the prevalence for the ER visits, it's very high in a male children under the age of 15 as compared to the overall population. So this is also one of the concern of the ER visits, and and the challenges related to the ER visits. So why it is important to me to speak about asthma on this session? It's really important for me to speak as a program manager in a Vermont Department of Health. So it's really important for us as we are working in asthma, and also I believe that if you can able to prevent, and also can raise an awareness for the self-management education, so that can lead to we can reduce the prevalence for uncontrolled asthma. So this is why it's important for me to work on this very important work on asthma. We are working on so many things, but it's really important for me. These three things: one is like prevention. We are working on creating awareness through asthma self-management education, and also media campaigns by working with other colleagues in our department, which can ultimately lead to improved quality of life and also reduce ER visits. I also wanted to be a voice for the vulnerable population. And my goal is to like improve health equity, which is like not really possible without like building collaborations and engaging with other stakeholders, especially CDC and my colleagues in other divisions, and especially with the schools, hospitals, universities, and community-based organizations for sure, and other external partners. So how exactly we are working on this so far? So we have a lot of strategies that we are working on currently. Say for example, asthma-friendly school recognition program. We are currently working on improving asthma action plans and envision programs. My colleague Michelle is also working on safe green cleaning products and other best practices, where we can create asthma-friendly schools to reduce the impact of the school children, asthma on school children. And we are also working on asthma self-management education to directly intervene that, and we are working on creating new platforms and creating awarenesses on adherence to asthma medications, and we are working with some national agencies for the public and policy reforms. And with this all get implemented through community-based programs. So community-based programs, we are working with some of the few community-based organizations to get all these strategies get implemented. So I wanted to take this opportunity to give a call, and we are also very so open and look forward to collaborate um, with anyone in this call to explore how we can reduce the impact of this uncontrolled asthma that causes on the children, which ultimately leading to low health literacy and low health equity. We are just like so open to collaborate with anyone, with any partners, to work on this together, because only one organization cannot able to do that. We need collaboration. We are so open to it, so, and we are so excited to work on this, to reduce the health equity and also the consequences it causes an impact on these children. So yeah, and we look forward to see for the collaboration. And finally, I wanted to thank my program, my department director, Moira Quick, and my supervisor, Rhoda Williams, and Karen Casper for very supportive for this meeting, and my other colleagues in my department. And I also wanted to take this opportunity to thank our funder, CDC, and other partners we are currently working on. So please don't hesitate to reach out to me or Karen. We are so open to collaborate and looking forward to explore to this important work. And thank you everyone for listening to me, and thank you for your patience. If you have any questions, we can take, or else I will pass it on to Dr. Teach, who will be focusing on focused best practices in schools on asthma. Thank you. I'll stop sharing my screen now.
Thanks, Volley. Really appreciate it. And welcome again to the asthma program. And we look forward to your assuming leadership over the program, and and thanks everybody else for being a part of an amazing collaboration and team, and for exploring always newer and better ways to tackle this challenge of uncontrolled asthma and asthma in general. So thank you. I appreciate it. I think maybe in the interest of time, if you don't mind, Vali, we'll go on, and then we can take questions at the end on topics, and move on. And so I'll turn over the mic to you, Dr. Teach, and in a similar fashion, perhaps give a small introduction to yourself, and then and then take it over as you wish.
Sure. Well, it's a pleasure to be here. I'm a pediatrician and actually a pediatric emergency medicine doctor. Has fairly recently relocated to Vermont from Washington, D.C., where I had a long career at Children's National Hospital and founded and sustained a program called Impact DC, or Improving Pediatric Asthma Care in the District of Columbia. And it was a morbidity focused program. So really the single biggest predictor of an emergency department visit for asthma, or a missed school day for asthma, or a sleepless night from asthma is having had one of those before. So we partnered with families who were using the emergency department for episodic asthma care and tried to turn the kid's situation around. So I've had a long-standing interest in this, and one small part of that interest is, or a significant part of that interest, of course, is collaborating with school nurses, because kids spend an enormous amount of time in school, obviously, and that's an opportunity to intervene both on the built environment, making sure that that's an asthma-friendly school, but also in selected cases, actually leveraging the school nurse program to be a more proactive part of the continuum of care. So that's where this concept of school-based asthma therapy comes in. And you'll have to excuse me because much of several of my slides really echo Dr. Volley's slides. We probably should have coordinated ahead of time, but let's see. There we go. Can you see the slides now?
Yes, they look great.
Oh, great. Okay. So we're talking about school-based asthma therapy today. And school-based asthma therapy is the administration of daily controller medications, generally inhaled corticosteroids or ICS, to children with persistent asthma, and we'll come back to that because that's a buzzword, persistent asthma, by school nurses or trained school-based personnel. So this radical notion that school nurses can participate in the daily treatment of children with persistent disease, and it's something that's growing nationwide and has a really good evidence-based school-based asthma therapy. And I always like to sort of start at the start. What is asthma? It's a chronic disorder of inflammation and constriction of the small to medium-sized airways. And what we need to remember is that kids with persistent disease in particular always look like their airways always look a bit like those airways in the middle. They're inflamed, there's mucus, there's episodic cough, particularly at night, and they are prone to those exacerbations. And so we're trying to catch those kids with asthma that fall in the middle there, that middle airway with that inflammation and partial constriction so that they don't end up with a more severe exacerbation that'll take them to the nursing suite, give them an even more sleepless night, end up in the emergency department, as Dr. Volley intimated, or hospitalized. So that's what we're after here, guys. We're after those kids in the middle with persistent disease. I wish it were that easy, and Dr. Valley intimated this. Asthma is a really complicated disease with a lot of individual and social factors, environmental factors, and medical care factors, so that any child with asthma, has a certain level of asthma control that's determined by all those different factors. And if that control is poor, bottom right corner, they have lots of symptoms, lots of uh, school absences, and more, it should say more ED visits and hospitalizations there. Little typo in the bottom right corner. I'm sorry about that. But you can see that, and what we're talking about today is that aspect of the plan that is the medication plan. What meds are the kids supposed to be taking? How adherent are they to those medications, particularly the daily controller medications? And critically important, what is their technique? I always like to say that, anybody can give a kid a teaspoon of Tylenol. That's fairly straightforward. But to give a kid an inhaler properly and make sure that that medicine is reaching the small to medium-sized airways of the lungs, that's a real skill, right? That's a real skill. And as a medical community, we generally don't do enough teaching and instruction around that. And lots of our kids and their parents have very poor technique with administration of inhalers. Dr. Valley touched on this. Lots of kids with asthma, lots of ED visits nationally. And what I always like to point out is that third bullet down, 14 million annual lost school days to asthma alone, with continued significant health disparities in asthma care and outcome. I mean, this is a ongoing, smoldering public health crisis for children. In Vermont, we're a little bit lucky. Morbidity nationwide is highly concentrated in urban environments, and we have only two or three really urban environments in the district. And just as an illustration of that, Children's National Hospital in DC sees greater than 1% of all the ED visits for asthma every year in our country. Really quite a striking statistic. Dr. Riley showed some of the data on this slide. In Vermont, we get our data from BRFIS and from the Child Asthma Callback Survey. We know about 10,000 Vermont children have asthma. That's a big number, and it's largely uncontrolled. About 60% or more of kids are uncontrolled. And among those states reporting a pediatric asthma prevalence nationwide, despite being a largely rural state, Vermont ranks in the top half. So we're in the top half of all the states reporting a pediatric asthma prevalence. That's kind of the bad news. Good news is things seem to be getting better both nationally and in Vermont. You see the black line there is the current U.S. prevalence of asthma nationwide, and this is data from the Vermont asthma program. And in green, appropriately in green, you see the current Vermont prevalence, and both of those seem to be falling a little bit most recently. So that's exciting data nationwide. Um, Inequities. Asthma is a really malignant disease because sadly it affects the most under-resourced children in our country. Just as a quick illustration of that, again, Dr. Valley intimated about this. This is the District of Columbia. This is your nation's capital. So this is Maryland in the upper right-hand corner, Virginia in the lower left-hand corner, and that diamond-shaped thing is the District of Columbia. And right here in the middle, that's the Capitol Mall. You know, that's right there is where the Capitol building of the United States sits. And what you're looking at here is at-risk rates of emergency department visits among kids 0 to 17 years of age. And so dark is bad. Dark is where the at-risk rates, so these are ED visits for asthma among kids with asthma. And the lighter color, this is good, the upper left-hand corner there, that's good. So what do we know about the District of Columbia? Well, the upper left-hand corner, that's where the highly resourced families live. The senators, the congressmen, the lobbyists, the the pediatric emergency medicine doctor. I used to live there. Um, Mainly non-Black, non-Hispanic families. Again, highly resourced. As you move towards the right and towards the bottom of the picture, family-based poverty increases dramatically, family-based unemployment, housing begins to deteriorate, and you end up with huge communities which are vastly under-resourced and where asthma morbidity is really high. And I always like to point out that several of the zip codes with the highest emergency department visit rates in our country, the most poorly controlled asthma in our country, lie within a couple of miles of the Capitol building of the United States of America. Really quite striking. And to me, that's always been a really clarion call nationally to really go after this disease to improve family-based health, school, child-based health, academic performance, and on and on and on. So that's all really bad, that's all really bad news. The good news is that asthma turns out to be a highly treatable disease. And these are the guidelines for asthma care from the National Institutes of Health, specifically the National Heart, Lung, and Blood Institute. And the NIH started publishing these way back in the 1990s, and there have been a series of updates and revisions, most recently in 2020. And the good news about these guidelines is they improve the care and outcomes of everybody, including children, wherever they're studied. Rural kids, suburban kids, urban kids, Black kids, white kids, Hispanic kids, poor kids, rich kids. It doesn't matter. If you apply these guidelines to their care, those kids get better. They cough less during the day, they cough less at night, their spirometry improves. Um, they miss less school and they stay the heck out of the emergency departments and hospitals, that expensive care that Vale alluded to earlier. They really work. What are the priorities of these guidelines? Because this really feeds into SBAT. Proper diagnosis and classification of disease, super critical. Patient and family-based education. Identification and control of triggers. This is bread and butter asthma care. And then critically, a clear medical plan, typically employing inhaled corticosteroids and now the long-acting beta agonists for persistent disease. And you've all seen the stoplight-based asthma action plan that we all love to use, the green zone, the everyday zone, the yellow zone, which is, you're starting to cough and wheeze a little bit, you're getting a cold, been exposed to one of your known triggers, and then the red zone where, I like to say the wheels are coming off and the family really needs to drop everything and attend to that child right away. And finally, it's a chronic disease, so the kids need ongoing and effective longitudinal care. Today, we'll be focusing on the medical plan aspect, particularly the ICS for persistent disease. So how does this work? Well, there's these two domains of proper classification: impairment, which is the sort of day-to-day ongoing symptoms that kids with asthma have, daytime symptoms, cough, wheeze, shortness of breath, exercise limitation. Nighttime awakenings, which for families is just huge. If you're living in the house of a kid with asthma and it's not well controlled, no one sleeps. It's miserable, particularly the child who's repeatedly woken up and then is sleepy in the morning, sleepy during the school day. And there's been some evidence, of course, that kids with persistent asthma have inferior academic performance. And then interference with normal activity, the use of short-acting beta agonists, the so-called SABAs, typically albuterol, and then spirometric values, or FEV1 percent predicted. They all help classify impairment by impairment. Risk, a little more straightforward. Risk are exacerbations requiring the use of systemic steroids. So you use impairment and risk to properly classify asthma. And the next slide is pretty busy. This is lifted directly from the current asthma guidelines. And this is for the different age groups. This is classification by impairment, you see in the far left. And you see crucially that distinguishing between intermittent and persistent disease. So kids with persistent disease, whether mild, moderate, or severe, those are the kids that are most likely to have daytime symptoms, nighttime awakenings, the need for frequent albuterol, interference with activity, and a bad spirometry, which is a measure, of course, of airway obstruction. Um, so persistent disease. And then you further classify, so you look at their impairment, and then you further classify by risk. And again, you're looking at kids with persistent disease. Those are the ones who generally have more frequent and intense events of greater severity. Typically, those events, by definition, require inhaled corticosteroids. Oftentimes, they involve a trip to a healthcare facility, an urgent care center, an emergency department, a physician's or nurse practitioner's office, and generally and rarely, but worrisome, it's the most common cause of hospital admission for older children. So persistent disease. And then once you have persistent disease, okay, then you go to the step-based therapy, and this is the cornerstone of modern disease. So, you're looking at management of persistent disease, and this is the chart just for kids 5 to 11, school-age kids of great interest to this group. And once you've diagnosed persistent disease, you can see in that top green row, and again, I apologize for the busy slide, a lot going on here when you get into the weeds. But if you just look across here, you see that it's that daily inhaled corticosteroid, the ICS, which becomes indicated for persistent disease. And you step it up as the kid remains under uncontrolled. So ICS for persistent disease. And I wanted to walk you through this. Most of you know this, but sometimes it's good to see it, laid out from the guidelines themselves, because this is what really justifies, in my mind, the use of SBAT in when families and school-based nursing and community-based clinicians come together when they feel it'll benefit the child. So now we've circled back to SBAT. Conceptually, what's going on with SBAT? The school-based health team is now delivering the top 2 zones of the asthma action plan. So nurses have long in the schools focused on the yellow zone. They've got their yellow zone instructions. They know that if the kid starts coughing, wheezing, shortness of breath in the school, they have a means by which to address that, typically with short-acting beta agonists, albuterol, given as puffs with a spacer, again, using really, really good technique. SBAT asks the school-based nursing staff to embrace the green zone. Okay, these are the daily controller medications to control the swelling and inflammation that we saw in that very first slide. And specifically, SBAT shifts the administration of daily controller therapy from the home to the school. And as I've mentioned, typically that is, ICS-based therapy. Why? Why do we want to do this? There are really 3 reasons why we want to do this. For families that clinicians, whether they're the school-based nursing staff or the community clinicians have identified. There are really 3 adherents. And that is, number 1, it's adherence. So it's adherence. The family really is struggling with getting the medication into the child properly on a daily basis. The second reason we like to do this is adherence. The family is struggling. And the third reason is adherence. I don't mean to make light of this, but many, many families struggle with the daily challenges of administering ICS. And we know why, those of us who work with families and with children. ICS is tough. It's every single day. It has to be given with a spacer. It has to be given with a child standing up using really, really good technique. And families are really, really challenged with that. Some are. Work schedules, single moms, single dads. Sometimes the grandmother who may have arthritis is trying to give the spacer and the inhaler. The spacer and the inhaler get lost. Families rushing to get out of the door in the morning. They're exhausted at night. And, simply this falls by the wayside and the kid is not getting the medication. Or if they're getting the medication, they're not getting it properly with a spacer and everything. And SBAT has been demonstrated to significantly improve asthma care and outcomes for kids with persistent disease. So think fewer symptom days and nights, less missed school. It really, really works. The champion of this nationally has been a longtime friend of mine, a Dr. Rachel Halterman, and her multidisciplinary teams, school nurses, social workers, parents, and clinicians have really come together in Rochester, New York to really be the champion of this, focusing again on under-resourced and families with a fair amount of home-based, chaos is a strong word, but home-based challenges. She's worked with those families and demonstrated in randomized control fashion that this really, really improves kids. How do we do it? Well, it requires a lot of collaboration, and that's one of the challenges we'll come back to. A lot of collaboration among the community clinician, the school nurse, and of course the family. So the clinician completes an updated asthma action plan and those forms needed to allow for the daily administration of ICS by a school nurse or other qualified personnel. The family then brings the ICS inhaler, an albuterol inhaler, and a spacer to the school. The school nurse or qualified personnel administers the morning dose of ICS to the kid every single day that school's in session and continues to administer yellow zone albuterol as needed. The family continues to administer any needed PM doses of ICS. at home. Challenges, lots of, this is the how, this is the challenges, and this is what is really the difficulty in getting SBAT going. It's a real change in culture. This idea that schools are going to intervene in the ongoing longitudinal daily treatment of children. School nursing is I've been partnering with them, with nurses for years. It's a finite and very stretched resource. As I like to say, school nurses are already dancing as fast as they can, and we're asking them to do more. School nurse turnover is a big issue. You guys know better than me. Some schools without any nursing coverage at all in the morning when we'd be doing this, and there's a reliance on non-nurses to administer the mids. There are insurance difficulties. Typically, insurance will only pay for one inhaled corticosteroid at a time. Real challenge there. And school's only in session a certain number of days per year, so families must administer those morning doses on the weekends and over vacations and summer breaks. There also seems to be a drop in efficacy among adolescents who typically administer their own medications. And we haven't seen as strong a signal among adolescents with school-based asthma therapy. And there's a little bit of a curveball coming out, and that is the advent of SMART therapy. SMART is a single maintenance and reliever therapy, a combination of an inhaled corticosteroid with a specific long-acting beta agonist called formoterol. And SMART therapy is a little bit tricky, but can be used for SBAT therapy very, very easily. But again, SMART does not use albuterol. It uses a single inhaler using both an inhaled steroid and formoterol. So these are the challenges. They're very, very significant in SBAT. The opportunities: better sleep, fewer missed school days, fewer trips to the nursing suite for yellow zone management, fewer ED visits and hospitalizations. And then, although this hasn't been studied, one can speculate that these kids are going to have better academic performance because they're going to be sleeping at night, more stable employment for caregivers. Many parents have told me over the years, I just had to stay home from work because the kid wheezes too much. And greater satisfaction among school nurses because they're really stepping into the breach here and doing something to help that child and that family succeed. We have some good news in this regard. Just this week, the Leahy Institute for Rural Partnerships, based at UVM, awarded a $10,000 grant for 2025 to a highly collaborative and multidisciplinary team that I will lead, and it will fund an exploration of the feasibility of expanding SBAT across Vermont. And rest assured, I'm going to be pulling all of you into this. We're going to be doing lots of focus groups, lots of key informant interviews with all sorts of stakeholders around the state, help understand the challenges. The deliverable will be the what I'm audaciously calling the Vermont State Guide for School-Based Asthma Therapy. And we will seek funding in 2026 from the Leahy Institute once we have this kind of consensus build around this for more for robust implementation statewide. I think there's real opportunity here, guys. It's been shown elsewhere. It doesn't sort of depend on new infrastructure. Instead, it leverages existing infrastructure. So I think I went right to 9:40, Karen. So there it goes.
Well, thank you so much, Dr. Teach. Despite that we're right at the time, I do want to bring attention to a question from, and you did address it in your following slide, but Caitlin asks, is there data yet on showing how that SBAT continues, even SBAT continues to be effective in schools where there isn't a school nurse present daily? And you did talk about other staff participating on that
Right.
health team. But do you find greater resistance where and or capacity challenges in those under-resourced schools?
clearly that's going to be a challenge and a risk to the program. And I think that's part of this sort of listening tour we're going to be doing in 2025 to try to understand that specific challenge and the others that are going to be the barriers and try to come up with ways to surmount them. But yes, that's a concern for sure.
Well, we're excited and congratulations on the Leahy grant. And we look forward to hear from you more. And feel free to drop questions in the chat. And if we have time, we can circle back on this. And as I say, we'd love to hear more as you get going under this grant and continue to expand these efforts. And we're really excited that others are working on this issue of uncontrolled asthma. So thank you, Dr. Teach. I'd like to now turn over the mic to Caitlin Kotzis, our state school nurse consultant. Caitlin, you want to take things over?
Yeah, good morning.
Good morning.
It is so hard to follow Dr. Teach in that wonderful presentation. So I'm just going to be expanding a bit more on school nurses and school health. Let me know if you can see my little presentation slides here.
Yes, we can. They look great.
And I can't see the chat, so in case there is any questions that pop in, my presentation isn't exactly 15 minutes long, so you can just, Karen or anyone,
Okay.
just feel free to kind of interrupt there.
Sounds good.
So good morning, everyone. My name is Caitlin Kotzis, and I am the State School Nurse Consultant in the Family and Child Health Division at the Vermont Department of Health, and I am really excited to be here with you today. The purpose of my presentation is to discuss asthma management in schools and how school nurses can effectively collaborate with healthcare providers to ensure the best care for students with asthma. I want to first highlight the important role of the Office of Local Health School Liaisons in supporting school nurses and providers in Vermont. I do believe one of our great liaisons is actually going to speak after me, so I'm going to leave this really high level. The liaisons play a real crucial role in connecting schools, school health teams, and school nurses with healthcare providers and public health resources. And each of Vermont's 12 local health offices has a school liaison who is either a public health nurse or a public health specialist. And if you are interested in building any kind of connections with local schools or school nurses, I really encourage you to reach out to the liaison in your area. There is a list of the liaisons, or I should say their contact information can be found on the Office of Local Health webpage under the district name that you are in. So, the impact of school nurses in asthma care. School nurses really play a critical role in managing a student's asthma care and are part of the child's treatment team. I always like to say that they are part of the child's treatment team just because they're not in a hospital or an outpatient office. They are still so important. For those of you who are providers on the call, you may see a student a handful of times a year, but school nurses have the potential to interact with a student in Vermont 175 times throughout the school year. That's not including after school or weekend activities that may occur or summer school. This gives school nurses a unique insight into how the student is managing their asthma. Due to their interactions during the school week, the nurse can monitor symptoms, track patterns, and intervene when necessary through collaboration with the student, their family, and the healthcare provider. Relationships created between the child and the school nurse can also assist the treatment team in identifying potential triggers in the places that kids really spend most of their time, in school and at home. Nurses are often the first responders to asthma emergencies and are trained to respond quickly and appropriately. Their expertise can be really life-saving, especially if the symptoms escalate to a severe level, and especially in some of our rural schools where emergency responders can be at times up to an hour away. School nurses can also help train, and they do help train and prepare staff in schools for possible asthma emergency situations. Another big role of the nurse is medication administration in school. In some school settings, school nurses may need to delegate this administration of asthma medications to assistive personnel such as teachers or paraprofessionals. There is unfortunately not always a school nurse present in the school. Delegation is done based upon the nurse's professional assessment of the situation and the child and their treatment. This is to ensure that the delegate has the appropriate training and support that is needed. Moving into the legislative world a little bit, there is a Vermont law, 16 VSA 1387, that permits Vermont schools to allow students with life-threatening allergies or with asthma to possess and self-administer their emergency medication at school, on school grounds, at those school-sponsored activities, on school-sponsored or school-provided transportation, and during school-related programs. School nurses are really instrumental in the implementation of this law within schools. Another responsibility of the school nurse is the creation of the Individualized Health Plan, or IHP, for students with special health needs, which includes asthma. It is crucial that school nurses have their updated asthma action plans for students, as these plans are created to ensure that the students' health needs are managed effectively and safely during school hours and are based upon input from both families and healthcare providers. The IHPs and the AAPs are regularly updated to ensure that the students' health needs are being met. School nurses also play a crucial role in individualized education plans, or IEP, and 504 planning, as they ensure that students receive the necessary medical support to fully participate in their education. And then we have school nurses who provide asthma self-management education, or ASME. And this is given to students with asthma by the school nurse. And through ASME, nurses teach students how to recognize symptoms and triggers, use their asthma action plan effectively, and understand when to seek help in an emergency. School nurses also provide coaching to help students assess and improve their asthma control and really empower them with the skills and knowledge needed to manage their condition successfully. By receiving ASME, students with asthma can better manage their health, reduce their symptoms, and maintain a safer and more active school life. What else are school nurses? They are champions for keeping their schools asthma-friendly by influencing their school and district policies and educating their school community on those best practices for managing the school environment. Ultimately, it is the school nurse and the school health team's mission to ensure that school is a safe, a supportive, and an inclusive environment for students with asthma. So, how do school nurses impact students with asthma? Research has shown that school nurses do help reduce the frequency and severity of asthma attacks in students. They improve school attendance and classroom seat time, and they can reduce school absenteeism due to asthma. A really important member of that team. Oops. Go back one. Here we go. So, managing asthma in schools does come with some challenges. One of those primary challenges is the potential for changes in medications mid-school year. A student may have their medication dosage adjusted or may switch to a new medication, and this really requires good communication with the school nurse to ensure that proper care is given in schools. In these situations, it's important that the asthma action plans are kept updated and sent to the school nurse as soon as possible. This helps the school health team provide the right care and respond quickly in case that there is an asthma emergency. Another challenge that we hear about is confidentiality and communication between school health teams and provider offices, specifically in regards to HIPAA and FERPA. I am taking the following information that I'm going to provide to you about HIPAA and FERPA from a really wonderful American Academy of Pediatrics learning burst that afterwards I can provide the link for if people are interested in that. So for a little broad overview, health records maintained by a school is considered to be part of the educational record, and that is covered by FERPA. Written parental consent is needed to disclose these educational records that have personally identifiable information. HIPAA applies to health plans, healthcare providers, and others that transmit health information electronically. HIPAA also requires written consent before disclosing protected health information. Now, FERPA and HIPAA information can be shared between schools and healthcare providers with a signed FERPA and HIPAA compliant consent form. And in a perfect world, and what best practice is that these forms will be signed. But unfortunately, we know that that's not always true in every situation. So there are situations in which educational health records or other health records can be shared without consent. For educational records, those can be shared without consent amongst teachers and other school staff who have a legitimate educational interest and in an emergency situation necessary to protect the health or safety of the student or another individual. For HIPAA protected information, that can be shared without consent with other healthcare providers for treatment purposes. Spoiler, that is a school nurse that falls under that category for sharing of treatment plans like an asthma action plan, or to treat a patient during an emergency or in the case of an imminent threat. So this is a case example that was created and shared by the American Academy of Pediatrics, but I really thought it was relevant to share with all of you today. So here's the case example. Arthur has been coming to the nurse's office several times a week during school to use his rescue inhaler. The nurse feels Arthur's asthma is not well controlled and would like to share this information with Arthur's pediatrician. What does the nurse need to do in order to share this information? So in this situation, the nurse would need a signed consent form from Arthur's parents in order to comply with FERPA. Without that consent form, the nurse could only speak with the doctor in an emergency situation or to verify information that the doctor had provided, such as on an asthma action plan. On the other hand, if Arthur's pediatrician wanted to update the school nurse about a revised treatment plan or new details about Arthur's medical needs, they would be able to do so without a signed consent form. It is best practice to have a signed consent, but in those situations, we do know that school nurses have been calling saying, hey, I really need an updated asthma action plan. And if there is an update, that can be shared from the provider office to the school nurse without signed consent. Moving on to a really Vermont-centric wonderful resource that we have is the School Nurse Asthma webpage. This past year, the asthma team created this wonderful website, and it is truly a one-stop shop for asthma resources for school health teams. And it offers school nurses resources, tools, and tips to support their students with asthma. Then my key takeaway from this morning really is that collaboration between school nurses and healthcare providers is essential for improving outcomes with students with asthma. By working together, they can ensure that students have up-to-date asthma action plans, effective medication management, and a clear understanding of how to manage their asthma both in school and at home. The partnership between school health teams and the child's provider, which is based in communication and collaboration, not only helps prevent asthma exacerbations, but also supports students in staying engaged in school activities, which leads to better educational and health outcomes. So that is all I have for this morning. I will put some of those links in the chat if interested.
Great. Yeah, thank you, Caitlin. Very informative. We really appreciate it. Just see if there's at least, let's do one question or comment. The one I had, Caitlin, was this issue of the HIPAA and FERPA. I've always wondered, you know, within a particular practice, the team is considered part of that team, and they're not doing consent forms amongst the nurse and the doctor, and you know they're considered part of the care team. And why is the school nurse not considered an extension of that health team? In other words, you know, making the need for that consent you know, no longer necessary. I know that's just a wish list more than a question, but solve the problem.
Well, so the different health records fall under the different, so HIPAA is for the providers and FERPA covers the school health office. So really in order to communicate between the two, there needs to be that signed consent. I know that there is conversation of potentially creating a national level bi-directional communication consent form, but we are unfortunately just not there yet. So this is something that I know has been plaguing both school nurses and provider offices for a very, very long time. And that's why just having those communication and collaboration techniques in place between school health offices and provider offices is so crucial. And that's really where the importance of our school liaisons come in.
Yeah. Well, thank you. And just a back at you for all your support in helping build out that school nurse webpage. It couldn't have been done without you and Nate. Thank you so much. All right, in the interest of time, I'll move on. And as you mentioned and highlighted, we're very pleased to have one of our school liaisons and a chronic disease designee present today. Jessica, Jessica Leclerc is with us. Jess, you want to take over the mic?
Sure. Yes, I do want to draw people's attention to the chat where Caitlin put the HIPAA FERPA learning burst from the American Academy of Pediatrics. It's really a great resource for knowing more about how it works. And I would also add that another resource that I would love to see that I've talked a little bit with Heidi about, but would love to elevate to the health department too, is if we considered having a web site that had all of the school consent forms and all of the provider practice consent forms, because typically what happens is the family is either at the provider's office or at school, and they say, yes, we want to be able to communicate, but only one consent form is there. So even though they've sent the consent form in, the other end of it can't communicate until that both are done. And that's a real barrier. So, it would be great if it was on our website, just saying. So I made that plug, and now I'll get started. So before I show my presentation, I'm just going to say that not only am I a school liaison and I'm a public health specialist, but I'm also a mom of a child with asthma. That's now not really even considered asthma because he hasn't had any issues with it in years. But when he was little, when he was this age, we were in and out of the hospital many times for asthma. It was very, very challenging. And now he's this age and he's doing great. So it's nice to have to have had that experience. It was scary at the time, but I think it does, make this even more meaningful to me to engage in this work. And I'm going to show my slideshow from the beginning. Hit that. Okay, there we go. Can everyone see it okay?
Yes.
Okay, so today I'm just going to talk with you a little bit about the role that the local school health liaison can play in promoting asthma-friendly school participation. Some of this can also, because I know there's a lot of other public health specialists or chronic disease designees on the call, and some of this can fall into your work as well. But the school liaison is best placed to do a lot of this work because they already have the relationships with school nurses. So that's why I focused this on the school nurse role. Just like Caitlin shared, we have health offices all around Vermont. These are not geared directly to county. I mean, some of them are just one county, like Bennington, but Morrisville, for example, serves a few different counties. Even me and Burlington, we're just Chittenden County, except for Buell's Gore. So there's one part of Chittenden County that's not in our area. But you can click on the link here of finding your local health office, and you can figure out who your school liaison is. So school liaisons work in the health and wellness realm, and although people often use those terms interchangeably, we're using the definitions of health being your state of physical, mental, and social well-being, with wellness more the pursuit of good health through the choices that people make. But keep in mind too, just like when Dr. Teach was talking about how asthma is different in different communities, the social determinants, the conditions under which you live, influence your health and also influence your wellness, influences the choices you're able to make. And the reason I brought that up is because we use two different frameworks. One is kind of more focused on health and the other on wellness. So the EPSDT framework is the framework that school liaisons use that is focused more on the health end of it. There are many health professionals who work in schools, from school nurses to mental health clinicians and even dental hygienists in some cases. And the liaisons help support programs that lead to more children, especially those who may have barriers to healthcare in their way, get access to the healthcare they need to be healthy and ready to learn. We also use the WISC framework, and this is the framework that also falls really nicely into the CDD role. But school liaisons promote wellness using the whole school, whole community, whole child, or WISC model. So this is the CDC's framework for addressing wellness in schools. And if you look at the model, you can see that the child is at the center, and the goal is for every child to be healthy, safe, engaged, supported, and challenged. And also the WISC model emphasizes the role of the community in supporting the school, the connections between health and academic achievement, and the importance of evidence-based school policies and practices. And you can see here that the physical environment, health education, and health services are three of those components. And of course, they're the ones that most directly relate to the asthma-friendly schools work. So why do I care so much about asthma besides having had a child with asthma? You can see that health and wellness covers so much ground, and why should this be a priority area? So education access and quality is a social determinant of health, and asthma can impact students' access to education, leading to long-term impacts on health, well-being, and quality of life. People with less access to quality education are more likely to suffer chronic health conditions and have a shorter lifespan. We know from our own asthma data pages that Dr. Volley showed earlier, but we know that LGBTQ plus adults, female adults, adults who didn't finish high school, adults who rent, adults with an income less than 125% of the federal poverty level, and those with disabilities are significantly more likely to have asthma than adults in general. As Dr. Teach said, asthma was the leading cause of school absenteeism back in 2016, leading to nearly 14 million missed school days per year. Today, chronic absenteeism is an even larger problem with a lot of other reasons, but it is still a leading cause of absenteeism for health reasons. Students with persistent asthma are more than 3 times as likely to have 10 or more absences than their peers. Now, when you're in that category, when you're chronically absent in kindergarten and first grade, which is often when kids have uncontrolled asthma, the younger kids more are more likely to be in that group. They're much less likely to be reading at grade level by the 3rd grade. And when you're not reading at grade level by the 3rd grade, you're 4 times more likely to drop out of high school. So you can kind of see where this access to education becomes a real issue. It's an equity issue for kids with asthma. So how can school liaisons help support the health of students with asthma? Well, this is where Dr. Teach, what you were talking about, the SBAT piece sounds really exciting. We can help a close relationship between the student's medical home and the student's school nurse can make a huge difference in helping kids get their asthma better managed. When medical homes share asthma action plans with school nurses, they're better prepared to support kids. And when school nurses are able to share what they are seeing at schools, like the example Caitlin said of, I'm not so sure this is that well controlled, that benefits their mutual patient. So school nurses can provide asthma education, they can work with students and their families and support health. When they're seen as an extension of the student's primary care home, the school nurse is invaluable. I mean, what a great asset to a primary care provider. They don't even have to pay them. They have this person who sees their student 5 days a week. But in practice, school nurses are often underutilized. So local health departments, through their school liaisons and family child health coordinators, can help with relationship building between practices and schools to develop the systems for coordinating care that will make things easier for both providers and school nurses, with the ultimate goal of benefiting the student. So school liaisons can also promote the Asthma-Friendly School Initiative and support the development of asthma-friendly policies and practices within schools. As we well know, asthma can be exacerbated by factors in the school environment, particularly issues such as mold or harsh cleaning chemicals that have an impact on indoor air quality. Yet it doesn't have to be this way. Research has shown that creating healthy indoor environments and providing adequate levels of school nursing can all but eliminate the disparity in attendance between students with asthma and their peers. So when I was excited to do this, but when I went and talked with my school nurses, and I'm Chittenden County, so I have 52 public schools, 75 total schools that I work with. And most of my schools have a school nurse, even some of my private schools or independent schools. So when I talked with them about the Asthma-Friendly School Initiative, there was a reluctance among many to participate They were afraid that if they nominated their school, they would find all kinds of expensive problems that they couldn't address. And they were even worried that maybe they'll be penalized, kind of like health inspectors come in to a restaurant, that could happen to them at school. And this is partially because the criteria were unknown. They didn't know, like you push the button to do the checklist, but you don't know what's going to be on the checklist ahead of time. So I went through the asthma-friendly school nomination form and organized it into a Word document so they could see all the areas that they could assess themselves in. And I provided links to resources they could use in developing things if they don't already have a fragrance-free policy, for example. And in addition to the Word document, I made this PowerPoint, which you see the first slide of it here, that I could present to school nurses to promote buy-in. Ideally, I present this while they also have the Word document in front of them so they can be doing an assessment of their current practices while we go through it. So I've done this in a few different school districts already, and it's been well received. Here's an example slide from the PowerPoint. So list 3 potential criteria that they can give themselves a check for and a link to a resource for developing an asthma emergency treatment plan. So again, because one of the challenges facing school nurses is time. So if you can make it as easy as possible to create positive change, you're more likely to be able to help them get that work done. Providing resources and support makes a huge difference. So school nurses that already have an asthma emergency treatment plan that reaches at least one of the audiences would be able to put a check in that box. And if they said, you know what, by May, which is when the nominations close, I bet I could have one that would reach a second one, then they could put an X on those boxes in their checklist. I also share their own data. So I do this by school district or even by individual school because we do have that data. But here I wanted to share with you, let's pretend Chittenden County is a school. So this is Chittenden County's levels of how many kids are known to have current asthma and how many of those have an asthma action plan on file at school. So you can see that we can check off 1 point, because if you have at least 50% of students with known asthma having an asthma action plan, that's worth 1 point on the asthma-friendly school checklist. But at 65%, you can get another point. So if this was what I was showing to a group of school nurses or a nurse in a school, I might ask her or them or him or they, what is getting in the way of us getting to 65% of our students having an asthma action plan on file? And I have asked this question, and I've learned recently from school nurses in my area that some of the provider offices are reluctant to share AAPs with school nurses without families having filled out both their and the school's consent forms, which requires families to jump through hoops. As pointed out earlier, asthma action plans are able to be shared between healthcare professionals under HIPAA for the purposes of treatment, which is clearly what an asthma action plan is. So you actually don't need a consent form to share an asthma action plan from a provider to a school nurse. And again, I referenced that HIPAA FERPA learning burst. So this is an opportunity for education and also an opportunity for maybe those practices to share each other's consent forms with the school and vice versa, developing a practice of when you ask a patient to fill out a consent form for you, that you also ask for the school, or in the school's case, the provider practice, would be a good practice to help with this challenge. This is another data point. So promoting well child exams is worth another point. So I share the data with school nurses on how many of their children have insurance, which is something school nurses help families to obtain, and how many have had well child exams, how many have had dental exams. Here we can see that in Chittenden County, we do have a portion of students for which we were unable to collect data, but we do know that at a minimum, almost 1 in 6 students did not have a well child exam in the past year, and 1 in 7 did not have a dental exam. So what can we do to help families access medical and dental care for their children? So interestingly, when we started, nurses are telling me that when they're contacting providers for AAPs, it helps school nurses identify a barrier to care for some students. One of our practices was the provider of record for asthma action plans, and they said, "Hey, these aren't our patients." And it turned out that this particular provider had dropped a lot of patients for no-shows that the families said they never got notified. I'm not quite sure how the notification happened, But in other words, the family thinks that they have a medical home, but they don't. So this is an opportunity for school nurses to connect with families and support getting them back into a medical home. The last slide of the actual checklist in my slideshow in the point earning part of the presentation is this one. So it says school nurses have already seen all the criteria at this point for becoming an asthma-friendly school, and all of them are at least a bronze level already. And I would say most of them are at least a silver level. So they're already feeling pretty good about where they're at. But this slide gives us an opportunity to brainstorm other asthma-friendly best practices they may be doing or want to initiate. So I like doing this with a group of nurses if I can, because it's an opportunity to bounce ideas off each other. It's been fun to do. So once we've gone through all the slides, we then tally up our scores so nurses can see where they score now and think about what more they could do. And then we recognize the past winners from our county because, I mean, like me, everyone gets a little bit of competitiveness, or most of us do. So 4 of last year's 24 award winners were from Chittenden County, and 2 in 22-23 were from us. But as you heard me say before, we have 75 schools in Chittenden County, including 52 public schools, 5 independent therapeutics, 12 independent alternatives, and 6 independent religious schools. There's no reason that we should only have 4 schools that have gone the asthma-friendly school status. And that's not to say they're the only schools that would actually meet the asthma-friendly school criteria. They're just not participating. So if I got 26 of them to participate, I would be increasing my participation locally by 6.5 times. 39 schools, I'd have 3/4 of the public schools. So my goal is to get to 52, but we'll see what happens with this school year. So what I do here is I take them to the website, which I'm going to take you to right now. And let me just put it on this screen, because what you can see in real time, which is fun for them and for me, is how many. Oh, look, 4 of us in Chittenden County have done it. And let's see who has done it. Oh, Justina Starr. And look, and it has a little quote from her, talks about the number of best practices. And so I can click on individuals and talk a little bit about what they've done and then how great it is. And wouldn't it be wonderful if Chittenden County was full of these stars? And people are responding. They're pretty excited. So I'm really hopeful that this year we'll see quite an improvement locally in participation. So I'm not going to get too into this because I know the Asthma-Friendly Schools program is going to talk, but they do have recognition for the school that are sent to the school and asthma champions. I think that's great. I think school nurses and school nurses are supervised by lay people who don't always understand exactly what they do. So I think it's important to send this to principals and superintendents, put it in the media. There's ways to recognize school nurses and their important role in school systems. And that's the end of my slideshow. I haven't been able to see the chat the whole time I've been talking, so I'm going to stop sharing my screen. And if anyone has any questions, I'm available to answer them, or we can move right into the last part of the presentation.
Yeah, thank you so much, Jess. Really appreciate it. And for all the various highlights here. If there's a question, we'll take one. I do want to, yeah, Dr. Teach, did you raise your hand? Did you do anything or you just moved?
No, I'm good.
Okay. Yeah, listen, I would highlight, I'm so excited about, our, emerging collaboration with you, Jess, and also with, we've been long trying to continue to enhance our connection with OLH and engagement with school liaisons. And we've had, on and off successes with that, but I'm very excited around, work with you. I think the next, we'll move into this next section, and I think we're, beginning to focus on similar needs of trying to simplify the asthma friendly schools criteria, making it a little bit more accessible. So to be able to get feedback to see you trying to engage into the community in an applied way and to then share ideas. I've already jotted the idea about enhancing our webpage with those forms. This collaboration, this is how and why collaboration around a common topic is so important, because from all of our working perspectives, it can only, make us better as we go along. So thanks. Really appreciate it. Let me go ahead and turn over the mic to Emily. And then at the end, we're getting close to, crossing over on our time targets. But hopefully we can revisit some of these issues at the end. Emily, why don't you take the mic and continue on in the theme of that Jess has laid out for us?
That's good. Thanks, Karen. Hi, everyone. My name is Emily. I'm from Professional Data Analysts, or PDA, part of the external evaluation team for the Vermont Asthma Program. And this summer, in late August, we started putting together 2 different documents, kind of in response to what a lot of Jessica was talking about. So I'm going to share my screen with those documents and just do a quick walkthrough of those. So the first one here is a 2-pager to give a brief overview about what the Asthma-friendly school program is, to make it a little bit more approachable, showing these 3 steps, saying you're doing what you're already doing. There might be some things you can expand on, but assess and implement asthma-friendly practices, and then nominate your school each year. And then number 3 is to go for gold. So we know that this is a continuous effort to make schools asthma friendly. So a brief overview of what the program is, along with a link to the website. And then the second page here is kind of a little roadmap to give people a taste of what making their school asthma friendly, what it might look like. So it kind of takes you through a brief little roadmap of some questions, like, have you identified students with asthma? Are there plans in place to manage asthma at school? Is your school using asthma-friendly products? Is your school taking steps to improve the school environment? And are school staff trained as needed? So this is just kind of like a teaser of what people might already be doing. That's part of that, making your school more asthma-friendly. And then the second document that we created is that list of criteria for people to look at. So it's squeezed onto 2 pages for people to see the different criteria for the Asthma-Friendly Schools program. Really clearly outlines how many best practices you need to be implementing to reach each stage, bronze, silver, or gold. And then it does have some clickability where you could cross things off if you are doing these practices. And it's organized in groupings, so people can see it before they go into the survey and submit their school to be nominated. So here's the second page here. All of the criteria are listed, and these are intended just to help people get a better sense of what the Asthma-Friendly School program is, what the criteria is, hopefully make it feel a little less daunting. And also there's contact information if people have questions on each of these documents as well. But I will pause there and pass it back to the asthma program team.
Okay. Thanks so much. Rhonda, you have a question or comment?
I mean, I'm just loving all this, these presentations, like similar to the comments in the chat. But I was thinking that maybe in 2025, we could look at the school nurse data in respects to which schools have done the asthma-friendly school recognition program and start to look at to what extent, we know this takes time. We might be seeing uptick in the measures that we want to see in asthma-friendly schools. And then secondly is, depending on the focus group outcomes of your grant, Dr. Teach, is, maybe a year or 2 from now, we will be looking at a possibility of incorporating school delivered asthma management or school nurse delivered controllers into asthma friendly school recognition program. So just a couple of thoughts there. Again, thank you everybody for this great work.
Yeah. Yeah, thank you. Thank you, Rhonda. Yeah, actually, I'd like to turn it over just briefly to Lauren, partly to give her recognition for the great work she did on the website to um, add that interactive map. Lauren, I've kind of changed strategy on you, but if you are available and can put that up again, that would be great. I was just wanting to show that in Jess's um, presentation, she showed kind of mirroring what we're beginning to see is a doubling of participation in Chittenden County, but we're seeing that across the state as well. Just wondering, Lauren, if you would be able to manage her getting to 6.5 times improvement. Can you fit the stars in?
If we have more schools, can we fit the stars in? Is that what you're asking?
Yeah, if she
Yeah.
got it to 6 times more, could you fit it in?
Yeah, this is the second year that we've done this map. I'm a little sick, so apologies if my voice, if it's a little hard to hear me. Yeah, we just make the stars smaller. And the last year we had fewer schools. I think we had almost like double the amount in 2024 that we had in 2023. So like we've already made the stars a little bit smaller, and we can just keep making them smaller. Yeah, the more we have on here, the better. Absolutely.
Well, I personally love this, and as Jessica mentioned, there's this kind of it does tickle the competitive bug in everybody we hear, and then there's these lovely quotable quotes that are added through the nomination process that people can put in themselves about what they take pride in and what they feel really great about in terms of achieving. And so these are featured for those who have been recognized at one of the medal levels, bronze, silver, gold. So it allows us to kind of delve in a little bit more. So it's very exciting. We are looking to go for universal participation among schools, have a long, long, long way to go. Also, just a note in Jess's slides, she showed doubling, but they were different schools. So how to keep schools who participated in 1 year to continue to begin to incorporate it as an annual process. This is a challenge. And then, how to take those best practices and just have them integrated as good things to do for everybody's health, as well as those who are with asthma. Any last comments about this participation and contribution, Lauren?
I would just maybe point out that we have, if a school like this, the school, the Windsor School has won it in previous years, we also note that. So the more times you win it, or you gain this this recognition, sort of the more it shows up here, which is great. And we also have down lower on the page, previous award winner. So this is the current year and just a different format. And then we also have the previous years here too. So even if you won it last year and you didn't quite get around to it this year, you're still up here, which is great.
Great, thank you. And then I just mentioned that our effort focuses on, pretty much smaller items that, they're already doing as a result of a regular, state law and regulations, idle-free and tobacco-free zones and other things that are low-hanging fruit that could qualify every school for bronze level. But then there's 2 or 3 harder challenges, but important, very important. So Michelle, do you have a minute just to kind of highlight a few of the environmental and air quality items? And we'll delve into those deeper at a future meeting.
Yes, we are doing a fair bit of work on things related to cleaning products and fragrances and essential oils that can impact air quality and everybody breathing the air, but especially people that have asthma in schools and childcares. I'll throw a link in the chat to a 2-page flyer that we created called Cleaning Safely in Schools that people can check out when they have time. This is posted on our health department website. And it talks a bit about There's a law that requires safer cleaning products in schools. Talks a little bit about that and kind of what we've been finding in schools. Spoiler alert, they're using a lot of not approved products. And talks about how to identify and choose safer products and why it's important. It also talks about and defines what cleaning, sanitizing, and disinfecting are, because they're all different processes and they can require different products, and that's not always clear to people. So that's a really cool product, and we're working on something similar now specific to fragrances and essential oils, which is another big topic in schools, and we'll be able to share that when that's ready.
Thank you, Michelle. Really appreciate everybody's efforts in working in schools and focusing on asthma control in schools and in support of kids with asthma. There's the thought that kids' activity limitations are being limited and their concentration, just as affected by not being able to breathe easy, and these steps can and are shown to make a big difference. So thank you everyone for the efforts, the collaboration together to keep enhancing and evolving our programs and efforts are just very exciting and inspiring and make a difference. And just as we get to the end of our time together, I know we didn't have as much time as we always want for discussion, but I do want to draw your attention to the top of the chat. And this is the first year of a new cycle of asthma funding with the CDC. So we try to revisit our goals together and purposes and satisfaction and value added. And so if you would try to fill in this very brief survey, just kind of quickly does the one that Emily, maybe you can drop it back in. The link is to just kind of complete that. We're trying to get feedback, I believe, by the early next week. But if you could do it today, that would be great. And we'll be building it into our strategic plan for the upcoming 4 years. So any last comments, updates, urgent notes? Rhonda, mute. Were you going to say something?
No. I
Oh.
have ideas for future asthma advisory panel meetings, though. Thanks to
Oh,
all
great.
of you.
Okay. Write them down. Don't. Any other last hurrahs? Happy Friday, everybody. Happy holidays. Look forward to seeing you in the next gathering together. Always send ideas if you've got topics or presentation ideas, and wish you all well. Thanks to the presenters for your great contributions today.
Thank you, everybody. Happy holidays.
Thank you. Bye.